As you can see, we'll be talking about bioidentical hormone therapy, understanding women's decision-making process, and family physicians' views. So why should we care about this topic? We'll start off by getting a sense of the significance of menopause care first. Menopause is defined by the WHO as 12 months of amenorrhea after the last period, so it's diagnosed in retrospect. The average age of menopause is around 51 years, ranging from 40 to 55. And most women can expect to live 30 years past that point. The last Canadian consensus in 2010 actually said that this age group made up a third of the female population in Canada, and that was expected to rise. This time is actually associated with varying degrees of physical and emotional symptoms. Most common are vasomotor symptoms, which include hot flushes and night sweats, that affect about 60 to 80% of women. These symptoms can be associated with significant impairment in quality of life and also productivity. 15% of women reported having these symptoms for longer than 15 years. Many women have sought out different management options. However, hormones have been a superior therapeutic agent in managing vasomotor symptoms specifically. In the 1990s, hormone replacement therapy, or HRT, was commonly prescribed to women both in short term to manage their symptoms, as well as long-term prevention of osteoporosis and cardiovascular events. The Women's Health Initiative study, or WHI, that was published in 2002, which is a landmark study that identified increased risk of breast cancer as well as cardiovascular events, especially with women who used combined HRT, estrogen and progestin therapy. And that study was vastly publicized and resulted in women actually stopping their therapies themselves, as well as physicians decreasing their prescriptions of HRT. Now we're about 10 years past the publication of the WHI. There have been newer studies and secondary analysis of that study, which sort of questions the generalizability of those findings. As a result, many societies, including the Society of Obstetrics and Gynecologists of Canada, currently support the use of HRT or hormone therapy, as they call it now, to treat women for short durations who have significant symptoms. However, women and family physicians are still uncertain about the safety of HRT, and as a result, women have chosen to use different modalities, including bioidentical hormone therapy. So the term bioidentical is quite confusing in the literature. It can mean hormones that are identical to what is manufactured or what is circulating in a woman's body naturally, like estradiol and progesterone, but also bioidentical hormones or bioidentical hormone therapy describes custom compounded hormone formulations that are made for an individual woman based on a specific prescription. And in our theses, we'll be referring to the second definition. In turn, conventional hormone therapy, or HRT, like what our participants are more familiar with, will refer to all commercially available hormones, regardless of how well it resembles the body and how it's applied. Okay, so what is the issue with bioidentical hormone therapy? There really is very little literature, very little information about its safety or even its bioavailability, its absorption, and its effect. Menopause societies, particularly the North American Menopause Society and the International Menopause Society, do not endorse its use and go a step further to actually warn against possible increased risks. There is a lot of concern among specialists and experts in the field about the term bioidentical being misleading to women. So the existing literature primarily is made up of review articles and expert debates and discussions. However, there were 5 studies that were original work, 2 of which were qualitative and the remaining 3 were cross-sectional. What did those articles tell us? That the prevalence of compounded BHT use is about 20%, but that was in an academic setting in the United States that provided both BHT and HRT. Women did describe positive experiences on BHT, and we know that pharmacists who compound BHT are more likely to believe in its safety and its effectiveness. There are studies that looked at women's ability to access BHT and any impeding or facilitating factors to that. And one study looked at women's understanding about the term natural hormone therapy, which is used sometimes as a synonym to bioidentical hormones. There were no studies that looked at women's decision-making in choosing this modality. And there were no studies that looked at family physicians or as a matter of fact, any physician's experience with BHT and women who were on that therapeutic modality. So the purpose of this thesis was to explore women's and family physicians' experiences with BHT. We conducted 2 separate studies, one on women with the aim of understanding menopausal women's experiences in accessing this therapy, their decision-making process, as well as the patient-physician relationship throughout that process. The second study that looked at family physicians and their perceptions and thoughts about BHT, their experiences with women who used BHT, and the impact that their patient choice has had on the patient-physician relationship. So the methodology of both studies were quite similar. We used a phenomenological qualitative approach that utilized in-depth interviews with women on BHT and family physicians that cared for that group. This slide summarizes aspects of the methodology that are similar between studies. We paid a lot of attention to patient characters to make sure that we were attaining a maximum variant sampling. Semi-structured interview guides were used that were adapted and modified as new data emerged. The interviews were audio tape recorded and transcribed verbatim. Field notes were recorded during and immediately after each interview. And the analysis took an interpretive and iterative approach whereby themes were identified and refined. A team analysis approach where myself, Dr. Graham Reed, and Dr. Amanda Terry reviewed each manuscript individually and then met on a regular basis to consolidate our findings on an agreed upon essence of these women's experiences. We stopped data collection once the theme saturation was achieved, and that was basically when no longer more information was emerging from the data. So I'll talk about the findings of each study first, and then at the end I'll talk about their implications, both of their implications. So the first study, Bioidentical Hormone Therapy, Understanding Women's Decision-Making Process. And so this study, we interviewed 12 women from a BHT clinic within the London area. The women were on BHT for a period ranging from 3 months to 8 years. And we had half of our participants were actually on HRT at some point in the past before trying BHT. The following 5 themes emerged from the data: transitioning into menopause, quest for relief, decision to use BHT, experience using BHT, and the patient-physician relationship throughout the journey. The transition into menopause for the participants in our study was quite difficult. There were impressions of chaos and turmoil, and it was primarily as a result of suffering, the severity of their symptoms, confusion as to where it's originating from, as well as feeling helpless and isolated. And the following quotes are examples of what they said. One woman would say, you know, you can't be prepared for the cloud. It's like a gray cloud, you're living under a gray cloud. Another said, I felt at times that I was actually dying. I would really say that. I really felt that poorly about myself. And another, I felt so removed from everybody that I thought I was looking through a screened window, looking down at everybody else as they were carrying on their day. What made menopause really awful was that I was trying to get help and I just felt like nobody was helping me. This resulted in significant desperation on part of the women, and that was actually a very strong push factor or a strong fueling aspect to their quest for finding symptom relief. That theme actually is divided into 3 distinctive stages, which are highlighted in green. The first stage was a general search for a solution, the premise of anything that works. And then the second stage was once they discovered BHT, and that was primarily through word of mouth and witnessing friends and family members improve while they were on BHT. And then the third stage was a more focused search for a BHT provider. The decision to go on BHT involved 4 components: evaluation, resolve, reinforcement, and conflict. Most of the participants in our study sought out information about BHT before making that decision. They used different media sources of information, including books and magazines, and unanimously all of them quoted a certain book published by a celebrity that endorsed BHT, as you can see in the following quote. First, I read Suzanne Somers' book. That was my first step, and then I just looked it up on the internet. What really was a factor that influenced women in reaching that resolve to use BHT was a constellation of factors, both that, external information that they were receiving and their own internal belief. So many women said, BHT's philosophy made sense, it was plant-based, and it was more natural, as we can see in the following quote. I would have taken anything to just stop the symptoms, but the idea that these things are matching the body, are actually good for the body, I was willing to try that. It sounded better to me than the pharmaceutical just because it seemed natural. Once women experienced positive changes while on BHT, that reinforced their decision. However, they were conflicted by concerns about possible long-term side effects with its use, as well as their the extreme fear of recurring symptoms once they stopped BHT. The experience of using BHT was dramatic for all women in the study, as you can see from the following quotes. Bioidenticals absolutely changed my life. I feel better now than I have in my whole life. It gave me my life back. It saved my life. And the last quote, will I stop them soon? No, not on your life. I said I'm going to give up food before I give up my bioidenticals. So moving on to the patient-physician relationship throughout that journey, there was a clear demarcation between an initial stage and a second stage that occurred prior to discovering BHT and after discovering BHT. The first stage before discovering BHT, which involved the actual menopausal turmoil and their symptom suffering, they were looking at their family doctor as a lifeline, looking for help and assistance. However, once they discovered BHT and made the decision to try it, the family doctor's role was somewhat diminished to just being a stepping stone to their ultimate goal of finding someone who would provide them with BHT. During the first stage, when the family physician was looked at as a lifeline, women were hoping that their family doctors would share alongside them their menopausal transition. They wanted to feel that their doctors understood what they were going through and sympathized with them, as well as supported them through this time. As you can see in the following statement, there are many big stages in life, and menopause is one of them. I'd like to know that my doctor would take great interest in following along with me and encouraging the positive or the healthiest side of this stage. Many women were hoping for a preemptive approach to counseling, one that would educate them about what's to come. That was looked at as a means to sort of control their anxiety and fears about all the changes that they're going through. As we can see in the following statement, I feel that family doctors have a responsibility to provide women with a fairly comprehensive description of what happens, what to expect. And women were also hoping to have multiple management options to choose from and actually discuss those options with their physicians. And when that did not occur, it was quite devastating for a lot of women. And like the following participant stated, if family doctors feel that HRT is the only thing that they can do, and if it doesn't help, then I'm sorry, I can't help you. That's a horrible thing to hear. However, in stage 2, unanimously all women, regardless of how well their relationship with their physician was in stage 1, moved on to stage 2, whereby they were on a mission to find a BHT provider. They were hoping in that stage that their doctor would approach their request with an openness and an understanding of their own choices. As the woman, the following participant stated, I just wanted very much an acceptance. I wanted very much an open attitude, an open-mindedness. So moving on to the second study, Bioidentical Hormone Therapy, a qualitative study of family physicians' experiences and views. This study, we interviewed 11 family physicians from the London area. There was a very nice mix between male and female physicians, so I feel we represented both groups. They primarily worked in urban and academic settings, and the duration of clinical practice they had was about 5 years to 37 years. The following 4 major themes emerged from the data: physicians' impression of BHT, perceptions of patients' knowledge, the impact of BHT on the physician's role, and reaching a therapeutic balance. Physicians' impression of BHT was primarily they felt that they lacked the knowledge. However, they didn't feel that BHT was that much different from any other form of conventional hormone. One physician said hormones are hormones. And they felt that the term bioidentical was a bit of a gimmick, something that is used to sort of advertise BHT as something that is completely different than HRT. As we can see from the following quote, bioidentical hormone therapy is something that is probably none of us feel like we know really a lot. And yet, is that really true? Because in terms of our hormone replacement therapy, we've learned with pills, but then suddenly we're using manufacturer's topical. So how is that different than what this thing called bioidentical is? With regard to the physician's perceptions of their patients' knowledge, they felt that their patients believed that BHT was a safer alternative to HRT, and they linked that primarily to their patients' fear of HRT. And they felt that that was compounded by the medical community's reluctance to prescribe HRT. As we can see in the following quote, I asked them, patients using BHT, about it. Tell me, why did you choose this versus the other? And again, the same answer. They feel that it's more natural and therefore it will not be as harmful, because everyone has heard about the WHI study. Everyone knows what a bad thing HRT is. And so this BHT to them is not synonymous with HRT. It's a lesser evil, or not evil, even an evil. The impact of BHT on the physician's role was quite evident, primarily with regard to the traditional flow of menopause care. Physicians in our study felt that they no longer took part in following up their patients or in monitoring their therapy, and that was quite, they felt quite disappointed at that loss, as we can see in the 2 quotes. I wasn't in the driver's seat, I was in the back seat. I think on some level, I feel that as her doctor, I'm a little bit left out on the process. They approached this, they also reported that counseling at that time was not as effective. They felt that their patients no longer trusted their opinion, no longer trusted their ideas about hormones. And you know, you can see in the following quote, it depends who gets to them first. And this participant was referring to either the BHT provider or the family physician. Now, reaching a therapeutic balance was challenging for most participants, and primarily because they lacked the knowledge about BHT, they were concerned about its safety, and they had some fear about possible medical legal complications or consequences. How do you balance all of that? Sort of the feeling uncomfortable, not knowing this type of modality, and patients wanting it. Most participants identified that approaching their patients' requests with openness and willing to listen to their requests and accommodate their wishes was a key factor in maintaining a healthy or satisfying patient-physician relationship. As you can see, I think overall you have to make sure that it's an open practice to be able to discuss BHT. If you have a very paternalistic approach, then you're not going to get the person to talk to you. There was a lot of congruence between findings of both studies, and the following themes emerged: the complexity of menopause counseling, the dichotomy between women's and physicians' view of BHT, and the patient-physician's relationship. During the complexity, both groups of participants identified the important role the family doctor plays in reassuring women about what's going on and normalizing their menopause experience. They both put a lot of value in preemptive menopause counseling that had sufficient time to educate women about what's to come, as well as explore their concerns, fears, and wishes. The resolution to use BHT was identified by both groups to be a very critical junction in women's menopausal journeys. It was a time where women's views about their own care changed. They felt more empowered and hopeful, and so thus approached their intention to use BHT with that power. And it was a time where they looked at their doctors as sort of taking a sideline view, whereby they would just approach them just to get to their ultimate goal of using BHT. Women's fear of HRT and belief that BHT was a safer alternative was identified as a key factor in their decisions to actually go on BHT. And this is where the dichotomy arose between women's belief that it is safe and doctors' concerns about that belief. The patient-physician relationship was affected by BHT, whereby the doctor's or the physician's role was excluded to some degree from the patient's overall menopausal care. However, both groups emphasized the importance of listening and willingness to be open about this modality. As the following family physician said, as a family physician community, we could improve the menopause counseling process by being more upfront about our willingness to listen, because we don't make that explicit, and I think a lot of patients have the perception that it's them versus us. So with regard to the limitations of both studies, the first study, we recruited our participants from a single urban specialized BHT clinic. So we're really not getting an idea of the views of physicians that acquire their BHT through their family doctors. The second thing is that participants in our study were actively receiving and using BHT. So we might be sort of getting an idea of a subgroup of women whereby BHT worked miraculously for, and we don't have an idea about women who were not on it or no longer used it. With regard to the second study, the primary limitation was geographic, where we were able to interview participants from urban or academic practice settings, and so we are not able to capture the views of physicians who work in more rural settings or in non-academic settings. As we can see from the data, women who were in our study had significant desperation, and that was a fueling factor in them searching for relief. So really the family physician caring for women who are seeking BHT need to be aware of that dramatical shift in their overall menopause outlook. This making their therapeutic decision-making process quite complex, and one that needs compassion and empathy on the part of the family physician. Repeatedly, both groups emphasized the importance of counseling, proper counseling that provided sufficient time to educate women as well as understand their illness experience. Thus, a patient-centered approach is an ideal approach in maintaining the patient-physician relationship throughout that journey. Possibly incorporating discussions on BHT within routine menopause counseling may sort of troubleshoot any possible future communication gaps, as well as give patients another view, so that when they look up information, they may look at it with a more analytical view rather than just accepting it as is. Now, to be able to achieve the counseling that we're hoping for requires time, and that might be an issue with the traditional setup of primary care or family medicine clinics. A team approach would be a valid way to sort of overcome that. Incorporating nurse practitioners and pharmacists would provide extra time for patients to explore their needs and concerns, as well as a different perspective with that regard. So thank you for listening, and I'd like to thank my supervisors for all their assistance throughout this process. I couldn't have done it without you. Thank you.